Buenos días a todas y todos, y buenas tardes para
Good
quienes.
morning. Good morning, everybody. Good afternoon. Those of you who are already in your afternoon, I'm Gabriela Perrota. It's an honor for me to coordinate this activity. Let us first thank the team of Clapper, especially Melina Pais, who has been with us, supporting us to make this possible, and Rodolfo Ponce de Leon and Susana Cerrulla. Let us share our experience with these topics that have to do with pregnancy in girls under 15 and different aspects related to this topic. Let me start by telling you that it is possible to listen to the presentations in English or in Spanish. At the bottom of the page, a bit to your right, there's a globe that says interpretation, and there you can listen to any of the two languages. One of our speakers is going to speak English, so you'll have the Spanish version of that. On the other hand, I want to invite you. So if you wish, if you have any questions, please write them there in the icon where it says Q&A, and finally, those questions will be answered. Let me start by introducing Dr. Marisa Lebowski and Sylvia Bonserjan. Please, if you can turn. Dr. Marisa Lebowski is the president of the International Federation of Child and Adolescent Gynecology, and Dr. Sylvia Bonserjan is the president of the Argentine Society of Adolescent Gynecology, and Carlota Lopez Kaufman. She was the third one to organize this together with Pajo Club. Thank you, Gabby. Well, you already thanked in the name of all of us, but especially we want to thank Rodolfo Gomez and Melina Pais for organizing this webinar. It's not easy, and it's wonderful to have the possibility of interpretation so that Judith Sims can speak her language. This will be available on the website, so thank you for joining us. It's Saturday, so both the panelists and the audience are trying hard to be with us. Everybody, this is an effort for everyone. Well, thank you. Yes, I agree with Marisa. This is an achievement, and she had a lot to do with this. Just as Gabby, thank you for coordinating and for addressing this issue that has such an impact in our countries, especially leaving lifelong sequela to our children and adolescents. So anything that we can do to prevent a pregnancy in girls under 15, that should be considered as an achievement already. So let's enjoy this webinar. Thank you, Sylvia and Marisa. Carlota Lopez Kaufman, I ask you to then turn on your camera. Carlota, she's the president of the chapter of obstetrician gynecology of child and adolescents. She's going to share with us the survey on the starting sexual relations among adolescents, decision or cohesion or coaction. Well, thank you. So, pregnancy in girls under 15, abuse and sexual violence with their potential causes are among the most complex issues because it expresses and it conjugates sexual centers of human rights, justice, and law. It is an indicator, critical indicator of the situations of vulnerability in which girls grow and develop. And these pregnancies are the result of a lack or very low power of decision, and they are seen in circumstances that are beyond the control or understanding of girls and adolescents. And in this complex landscape of the Medical Association of Argentina for Contraception, we saw a need to see what was happening to our teenagers. And it was then that we decided to create this survey investigating the characteristics of the first sexual relations, the prevalence of coercion and decisions at the beginning, and further consequences, including pregnancy, abortion, um, um, STDs. So we developed a survey for 233 adolescents, and this was done in public schools, three of the province of University of Buenos Aires, two of the province of San Jose, and so the results were that girls started having sexual relations at 13.2 years as an average. And we divided the entire universe of adolescents into two groups. In group one, 52.9% started their relations at the age chosen by them, 13.2 years. The average age of couples was 16 as an average, 2.7 years as a difference. 88% had started with their sexual partner, and 3% with somebody they didn't know, and 0.6% with a relative. And in group two, 47.1%, although they had started their relations at an average age that was not chosen at 13.2, would have wished to do so at 16.8 as an average. The average age of the couple was 17.3%, with a difference of 4.3 years. 69% had started with their boyfriend, 0.18% with a friend, 10.5% with somebody they didn't know, 5% with a relative, and almost 4% with somebody else. The pressure exerted by the sexual partner to start was significantly greater in group two than in group one, 27% versus 8.2%. At the time of deciding when to start, 62% of the adolescents in group one did not feel pressed, versus in group two, where only 33.6% did. 67% of the girls surveyed reported having used a contraceptive method to avoid pregnancy, prevent either pregnancy or a sexually transmitted disease. But in group two, 21.4% had not used any contraceptive method, nor condoms. So in the total number of the surveys, there was 8.67% of pregnancies, 28 pregnancies. Only 4 teenagers of group 2 decided to interrupt it on a voluntary basis because it had been either a rape or they had been pressed at the beginning of the relation. Only 1.4% of those that said that they had taken care got an STI, versus 5.7% among those who said they hadn't taken any precautions. So as a conclusion, the circumstances under which sexual initiation in girls under 15 occurred in the context of violence could be confirmed through the results obtained in this survey. when comparing among the adolescents that had started their sexual activity at the age they had chosen and those who would have liked to do it later, we conclude the following. The younger the adolescent, the greater the odds of forced sexual relations. The decision of initiating sexual relations is not always a conscious decision, nor is it a decision where the girls can size the consequences and the impact. The age of the sexual partner indicates that even if it was against their age, it was accepted because they couldn't oppose to it. The time of decision and the multiple responses vis-a-vis a number of questions. For instance, I accepted, but I didn't want. I didn't accept, but it happened. I accepted, but I didn't have the time to think it over, or I didn't feel pressed. Showed coercion, rape, and the perception of physical, emotional, or both harm. The lack of preventive behaviors at the time of sexual relations became evident with the pregnancies that happened and the voluntary interruption in some cases. In addition, the sexual relations under coercion are usually not protected, and not being able to say no or not being able to request the use of a condom, of course, that makes them vulnerable to get STIs. Among the limitations that we found in this investigation, we point out the number of girls in the sample. We could think that given the conditions, the range of conditions, social and economic, it's very difficult to extrapolate these results at a national level. However, we hope that these results may contribute to enrich the existing literature and that they may be applied on the one hand to public policy and strategies for prevention and promotion of sexual and reproductive health, tending to ensure sexual life free of any coercion or violence and with pleasure, and so with informed and autonomous decisions. Thank you.
Muchas gracias, Carlota.
Thank you, Carlota.
Vamos a dar ahora la palabra a la licenciada María Eugenia Otero.
We now hand the floor to Maria Eugenia Otero from Argentina. She will speak of comprehensive sexual education, prevention of situations of abuse and violence. She coordinates the postgraduate course of comprehensive sexual education at the Joaquín González Teaching Institute. Thank you. Thank you, Fabi. It's a pleasure to be here. I celebrate this and other spaces where adults, professionals, health teams, and teachers think about. They say her volume is very low. Can you hear me better? Quite low. Could you raise the volume, please? And if not, we'll raise our volumes. Please. We don't hear you well, Eugenia, very low. Could you raise your voice then, please? Are we better now? It's okay, but very low. Could you raise your volume? Or maybe removing your headsets, I don't know. I tried. Well, we'll do our best. We'll do our best. Okay. I celebrate this space because we must think about our ideas and practices to make the world a better living place for girls and teenagers. When I work in comprehensive sexual education, I want to start asking those who are present at the meetings if they did have sexual education. And while I share my screen, I would ask you to make this question to yourselves, even if it's in silence. And I'll tell you something that always occurs when you make this question, that people say we didn't have a sexual education, particularly people in our generation, but also younger people. We didn't have real sexual education. And ultimately, the truth is that we did have sexual education. We all had it. And can you see my screen? Yes. It's not in the presentation mode. That's okay. Good. The answer is always no, I didn't have sexual education. And ultimately, what we hold when we work on the subject is that everybody had a sexual education. Furthermore, we were indoctrinated in relation to gender and sexual education at school. I give this example, but also at home, in the family, in the media, in the street with peers. We had many situations by which we were indoctrinated and disciplined as to how women and men ought to be, what behaviors and roles and places we could occupy. But apart from all that, something that we internalized when we learned all this, of that is how we had to behave. This has to do with hierarchies, with power relationships, with inequality and oppression that were also internalized. This is something that Ana Maria Fernandez, an Argentine psychoanalyst, says for being hit and raped and incest to exist, society has to have vulneralized and made fragile and inferior the social group to which this violence is addressed. Girls and teenagers and women are the weakest social collective, and this legitimates this sort of vulneration. So, in principle, we have to take this into account. This is a field where violence grows. How do we change it? The truth is that since sexuality began to appear as a manifest content at school, it has been approached in two main manners. One, biomedical, whereby they convey, or we convey, it still occurs, biological content. So we speak particularly of risks and hazards with sexuality and STIs, non-voluntary pregnancies, and then a more moralizing or religious approach, if you will, that sort of gives you an idea of how sexual intercourse has to be heterosexual, with reproductive aims, and within marriage and the family. In none of these cases, these models interrogate the power relationships or make any movements in relation to what ought to be changed in order to think where is that abuse occurs. Fortunately, and due to the drive of all the work made by different agencies and women's movements and so on, since 2006 in our country, we have this law 26150, creating the National Comprehensive Sexual Education Program that speaks of a sexual education including biological, psychological, social, affective, and ethical issues. It has different axes that are conceptual, caring for the body and health, appreciating effectiveness and guaranteeing gender equity, respecting, I would say, celebrating diversity and exercising rights. This comprehensive sexual education is a right for all girls, boys, and teenagers in our country that go to all public and private schools, professional, religious people at all educational levels, initial, primary, secondary, and superior education. All schools should include these proposals in their educational syllabus, and it's an obligation to train teachers to provide it. This is an obligation of the national states. We must know that much of the contents of sexual education, including documents and others, provide tools or promote learnings and capacities related with the fact that children recognize abuse situations related with tools for prevention of sexual violence against children and teenagers. This to show you some of the documents used in this comprehensive sexual education. I'll tell you now a bit what I prepared regarding the contents for each level, related precisely with the recognition and detection and prevention of abuse. Knowing, of course, that when we speak of comprehensive sexual education, we're not only referring to contents or information alone, but a position, a view, a critical view in order to accompany children to develop their autonomy and reach their own decisions. Thinking, of course, of what we just heard from Carlota, what things we ought to accompany so this occurs. At the initial level, we work with the parts of the body and how to name them correctly, the concept of intimacy and caring for one's and others' intimacy. We also work the manner of expressing emotions, feelings, and posing our needs, having patterns of care and behaviors with self-protection, discriminating at early age what physical interactions are not appropriate, to be able to have tools to say no when something makes you feel uncomfortable or confused, not keep secrets related with this discomfort, and working on possible secrets that shouldn't be kept, and indeed identifying situations where they may need help from adults. In the primary level, of course, we continue working in the care of one's and others' bodies, the progressive construction of autonomy. We work hard on relationships with peers, with fellow students in the family, and we begin to work the relationship with a partner, the right to intimacy once again, and the vulneration of this right, being able to recognize sexual abuse, gender violence, and traffic of people, prevention of grooming also. We work on recognizing emotions and feelings related with sexuality. I was thinking, and what Carlota said, whereby many girls said they had low decision-making capacity. They hadn't been able to say no, and for this they must acknowledge their feelings and emotions and strengthen their skills in the relation to their own needs. At secondary school level, we continue working in the protection and the care for oneself and others, of course, respectful and equal relationships. We initiate a critical analysis of the male and female characteristics, reflect on the imposed behaviors regarding the rights of others, developing skills to protect oneself from rights vulnerations, identifying behaviors that denote power abuse, and how this is articulated with sexual rights of children, recognizing and refusing discrimination, violence, abuse, maltreatment, sexual exploitation, and traffic. We work with the social media and sexuality, knowing that this occurs through the media, of course, knowing our rights and also resources and agencies that protect them. Of course, we have contents for teacher training, and I won't enter into details here. The truth is that every day in the training center where I work, we hear stories from teachers that are involved and committed with comprehensive sexual education and make this schoolroom a place where girls and boys may openly manifest what occurs to them, what questions they have, and also their suffering. That is, apart from generating a space in which to work, they can think sexuality in a very comprehensive manner. So because these children sometimes are not free to mention pain. This image is from a video from the song of a group called Cuenticos. This song is called Secrets, and it's of course related with all this. The secrets that are bad for us and abuse, and this girl is in the rain, and we work on abuse with these children, teenagers. We know that often this rain isn't rain but a storm, a real windstorm that really destroys subjectivity and leaves us very alone. And many times it's the teachers themselves that may put into words this violence and obligations and allow with this intervention, as we see here, this intervention shows first the need to believe in them, showing that we're there to protect them. And these people should accompany and transform the lives of these girls and boys and teenagers. The truth is that although at school we have a specific ambit for comprehensive sexual education, this law acknowledges that oftentimes we must guarantee it in the framework of co-responsibility. So many times this law works opening doors, and this is related with violence, vulneration of rights, and it involves and requires they be approached in a comprehensive and cross-sectional manner in different sectors with many players. So we need people to be involved to accompany these children.
Argentina has a marvelous experience that has to do with this, with a plan for the prevention of unintentional pregnancy in adolescents. And as I only had 15 minutes, I preferred not to dwell on this, but you can see the ENIA plan that where they work from the aspect of education and health to address sexual education to prevent unintentional pregnancies. I brought some examples of the media where here this highlights the importance of a comprehensive sexual education to prevent abuse. This is in Santa Fe. There were 368 cases of abuse detected in 2018 through the integral education, sexual education classes. This has to do with a statistic of the government of Buenos Aires. In their Gesell camera, they say that 80% of the people that could talk had recognized abuse after having a class on integral sexual education at school. More than 8 of 10 children report sexual abuse in the schools. This quotes the patient, a teacher who says, in a class of primary school, allows us to identify a severe case of abuse. And you say, and the girl said, he groped me where you told me that I couldn't be touched. So this is it's very important in integral sexual education to address this, to make it visible when there are abuse cases. Let me, a couple of minutes. So in spite of all of this evidence today, we have many discourses that started to appear against the integrated sexual education, including at a political level, that says that this is trying to create indoctrination. And even somebody said that what you needed was pornography. That was the way he had learned. And they also filled up graffiti schools where they taught integrated sexual education. And those of us, and because of all of this, recently, we created a federal movement to defend the integrated sexual education, and celebrating 40 years of democracy. We thought of 40 reasons we have to defend integrated sexual education. We know that there are many more than 40, but one of them is to prevent, detect, and to stop sexual abuse against children and adolescents. And another is to recognize that boys, girls, and adolescents have the right to be protected, and that this education prevents forced education, and it is teaching with tenderness, and so it's more than a law. It's the hope for full and dignified lives for all our world. Thank you. Thank you, Eugenia. Thank you. So now let me invite Judith Simpson-Dam, President of the United States. She will tell us how to approach the visits in the girls and boys under 15, in the pregnant adolescents under 15 years. Remember that you have interpretation in the globe, where you have interpretation at the bottom to the right. The PowerPoint presentation is in Spanish, but she will speak English. Thank you, Judith.
And I want to make sure that the translation is working well now. So this is a test, so everybody can hear. Please let me know if there's a problem. And thank you very much for the opportunity to have translation and to do this in English. If there's a problem, I can do it in Spanish, but this is much easier for me. So thank you very much. Today, I'm going to be talking about something that's very important to me, which is understanding the impact of trauma and how do we actually care for pregnant adolescents under the age of 15. So first, defining trauma. What actually is trauma? It's an event or situation or circumstance that results in physical, emotional, or life-threatening harm. It can lead to adverse events in mental, physical, social, emotional, and spiritual health. What are some of the common types of trauma that adolescents or children experience? Well, of course, we all know about their sexual assault and sexual abuse. It's also physical violence, natural disasters, hospitalizations, to witness very traumatic events like we see in times of war. There's the loss of loved ones. So some of our adolescents have lost family members. There's medical trauma. So actually having a medical illness and receiving treatment, such as chemotherapy or other strong, intense treatments, can be very traumatizing. Accidents can be traumatizing. And then, of course, obstetric experiences can be traumatic as well. And I'll talk a little bit more about that. Remember that trauma is defined by the person who experiences it. So where one event may be traumatic to one person, it may not be felt as traumatically to somebody else. We know that a history of trauma is a major risk factor for adolescent pregnancy, as you've heard a little bit about today. There are common explanations for adolescent pregnancy and motherhood and the association with trauma. Sometimes we attribute this to lack of access to education, sexuality education of high quality. And of course, this is so important. As was just mentioned by Dr. Ortero, we need high quality sexual education for everybody. Sometimes we talk about the risk for adolescent pregnancy being in relation to lack of social mobility. But trauma is also a huge impact as a risk factor for adolescent pregnancy. Why? There's a big impact of trauma on the neurodevelopment of adolescents and of children. It alters your identity formation. It increases risk-taking behavior. It impacts decision-making behavior. And in a twist, while society considers adolescent pregnancy and motherhood a negative thing, for some of our adolescents who've experienced severe trauma, it sometimes is used as their strategy in order to cope with their history of trauma because it allows something positive in their life. And some of you may have heard patients talk about, well, at least my baby will love me. So the trauma itself can really have impacts on how pregnancy is perceived. How does trauma affect brain development? We know that people who have suffered trauma since childhood learn to live in a state of survival, constantly activated. They don't have the experience of living life, but of surviving constantly in this state of alert and threat. So if you look at the triangles here, in typical development, a child will spend minimal energy just trying to survive because their parents or their caregivers are taking care of this. And it allows normal social and emotional development and normal cognition. Whereas a child who is in constant state of threat, we call this toxic stress, spends so much energy on survival that they have less opportunity to develop a robust socio and emotional IQ. They're just trying to survive. Their ability to reason is impaired precisely because of this continuous state of survival. As was mentioned by Dr. Carlota Lopez Kaufman, so importantly, forced pregnancy is such a problem in the very young adolescents. There was an excellent study done by Planned Parenthood called Stolen Lives that involved surveys conducted in Guatemala, Ecuador, Nicaragua, and Peru, and was published in 2015. It showed at that time in Latin America that 90% of the pregnancies in girls under the age of 14 years of age occurred as a result of assault, of rape. Due to shame, embarrassment, or not understanding what was actually happening to their body, young adolescents often presented late in care. The suicide rates were noted to be significantly higher in these young pregnant adolescents due to isolation and stigma and shaming, sometimes by even their caregivers themselves, who put blame on the young girls for becoming pregnant. And then, of course, where abortion is illegal or not offered, forced pregnancy results in higher risk pregnancy and increased rates of cesarean sections for delivery, which impacts a girl's reproductive life for the rest of her life. This was an interesting study that occurred in Turkey of 47 pregnant adolescents that they compared to 44 controls of the same age. And it looked at whether or not the pregnancy itself was traumatic to the adolescents. And it was a very well done study because it excluded adolescents with a history of violence, of domestic violence, of sexual abuse or rape. So it was looking at only the pregnancy itself and the impact and the perception of trauma and the development of post-traumatic stress disorder. In the group that was pregnant, in the study group, the rate of post-traumatic stress disorder was 42% versus the control group, which was only 23%. So almost double that risk. Interestingly, in this country, 74% of the adolescents who were pregnant were married. But the rate of post-traumatic stress disorder was actually higher in the married girls than in the non-married girls. And so it's important to realize that forced marriage does not protect against the trauma of pregnancy either. So it's very important that we talk about avoiding early childhood marriage, early childhood pregnancy as well. So what do we do? In this particular talk, I'm not going to talk so much about the prevention, but what do you do when you have a young pregnant adolescent in your clinic? How do you care for her? And the best approach is one that looks at trauma-informed care. Why is it so important to acknowledge trauma ourselves as providers? It's because both the patients and the clinicians are often really uncomfortable talking about trauma. There are barriers to these discussions on the part of the patients. For example, we all know that there's a very large power differential between patients and their providers and their physicians, but that's amplified even more when you have a young, pregnant teenager who feels embarrassed or shamed because of the trauma that happened, that may have a very poor body image, especially in the setting of sexual abuse. This patient may have experienced clinician apathy, so that the provider was so uncomfortable or didn't bring it up that they felt like they're not going to bring it up because nobody cares. Some of our patients have real lack of trust in our system because we haven't been able to protect them. In girls who've been seeing pediatricians for years, that this abuse wasn't detected makes them think, well, why bother to say anything? Because nobody's picked it up before. And sometimes girls who've had evaluations for sexual assault were so traumatized by that evaluation that they don't want to talk about it anymore. At the same time, there are barriers for patients. There are barriers for us as providers. Many of us have to become comfortable actually talking to our patients about this. Sometimes we've never learned in our medical education the language to use with our patients, how to even open these discussions. And some of us are just so tired and burnt out seeing patient after patient that to take the emotional energy to have these discussions is really hard. And I want to acknowledge that as well. There are also system level barriers. And I know here in the United States, we are counted on how many patients we see, how efficiently we're seeing our patients. There are time constraints in clinic. And all of us know when we have a very busy clinic schedule, that when a patient brings this up, we have to take a deep breath and know that we're going to be behind the rest of the afternoon, but that this patient in front of us needs us so very badly. The other barrier is many times when the patients present with these kinds of concerns or they disclose our history of trauma. What do you do with the information? I don't know about you all, but I personally don't have a social worker in my clinic when I am seeing my patients. So I know I had to develop my list of resources and a way to connect my patient from my clinic to these resources, but that can be a barrier as well. What are the indicators that when a patient sitting in front of us may have had a history of trauma in the past? Some real key presenting signals are avoiding talking about a certain body part, anxiety around physical exams, or especially among certain body parts, dissociation during the exam, not responding, avoiding interactions, being closed down, not saying anything. These are real signals that should make us stop and ask, okay, what happened? Sometimes patients will pull away and will hide their face during an exam. And many times we talk about wanting to plan for childbirth, but these patients oftentimes are too frightened to talk about how to plan for a birthing process and have a lot of anxiety about the idea of a vaginal delivery. This was a very elegant study, very important study that was published by my colleagues in Toronto, Heather Millar and her team. And the title of it speaks so much. It says, "No, you need to explain what you're doing. Obstetric care and experiences and preferences of adolescent mothers with a history of childhood trauma." And what they did was they did a study of 29 mothers and adolescents in Toronto, Canada, and then did 5 focused, structured interviews of some of these patients. These were teens that had presented with a history of at least 5 adverse childhood experiences, whether it was rape or sexual abuse or other forms of trauma. So they had had at least 5 of these traumas each in their childhood. The majority of them preferred, when asked, not to be asked about the trauma until after the clinicians knew them better. There was a total of 19 participants that reported that they were actually triggered by parts of the history and exam that was being done at the time of the evaluation. So the vaginal exam in the clinic or in the hospital was triggering for stress and trauma in about 27%. Abdominal exam and taking the vital signs, especially when the blood pressure cuff squeezes very tightly on your arm, can be very traumatizing. And only about a third of the participants considered that their clinician really understood how to take care of them in the setting of trauma. So what are the recommendations for really caring well for these girls who have a history of trauma? 1, avoid asking about trauma history at the intake if possible, and wait until you've established a rapport with the patient. Tell the patient about why you're asking about trauma and explain the reasons for your questions. As much as possible, ensure consistency with the providers and do not have multiple providers asking the same question over and over again. And explain the purpose of all medical exams, including things that are simple, like why are you taking my blood pressure and what it's used for. Provide as much control and options in who is caring for them as feasible. We all have experienced patients who really don't want to be taken care of by a male provider if they've had a history of sexual assault, but that is not often, sometimes it's the only provider who's present in the clinic or the hospital. So it's important to give choices when it's possible, but to explain why this person will be providing your care in as kind and as understanding a way as possible. Try to train our staff about trauma-informed care, develop a set of coping strategies and resources of your own to have available for your patients, and explore models of peer support when possible. So there are programs called Centering Pregnancy Among Teens where they actually provide young teens to provide group support. How do I try to make a safe and welcoming environment? I always sit down every time I talk to the patient. I try not to stand over my patient. I try to sit lower than my patient in my clinic. If my patient discloses a history of trauma, I try asking too many probing questions and let them talk to me. I say, what would you like me to know about this? And I always thank them for the privilege of the trust of disclosing that information. It's a privilege to be in that space. I teach students and learners, because I have learners in all my clinics, that if they read a note where a patient has a history of trauma and it has been disclosed, to not ask again about that. These are things that are sometimes very interesting to students that they want to learn more about, but they have to be trained that this is not the time and the place. And also when you're with patients, validate their anxiety, validate that their experiences can be traumatic. Always obtain.
Judy, excuse me, we are on time.
Okay.
Please.
I will stop. And these are some last resources for anybody who would like to learn more about trauma and how it affects the way we think. This is an excellent book. I'm glad to see it in Spanish now. El cuerpo lleva la cuenta. Thank you. Sorry to run over.
Thank you very much. Muchas gracias, Judith. Bueno, ahora
Thank
vamos
you,
a
Judith. Now,
ahora vamos a presentar,
we will hear.
no sé por qué estamos
I don't know
escuchando,
why we're hearing the
estamos
English.
escuchando la traducción, no sé por qué.
I'm
Ahí,
translating into the English channel.
pero te estamos escuchando aquí en la plataforma.
We're not hearing you. Maybe
Sí.
you have the wrong channel. Leticia.
Ahora creo que está bien.
Well, I think it's okay now. She had it wrong. Let's now introduce this video. I will introduce Dr. Fanny Corrales, president of SOHIA Paraguay, but she has a very poor connection, so she has sent this video and will speak on risks of pregnancies in under 15s. Please, could you share the video? Hello, everybody. I'm Fanny Corrales from Paraguay. Thank you for inviting me, particularly Dr. Marisa Lagos, our president. I must speak of the risks for pregnancy in under 15s in this interesting webinar. These are my disclosures. I don't have any for this presentation. The opinions and interpretations I will make are mine and do not represent the position of any of these organizations for which I work. The goals are to speak of concepts and epidemiology of teenager pregnancy in under 15s, the causes of the major obstetric syndromes here, why in adolescents, and the evidence. The most frequent concept we coin is that social factors for inappropriate prenatal care are the main cause of adolescent pregnancies, but ultimately the main pathological factor is what occurs with uterine immaturity. As you may see in Latin America, we have this slow fall of fecundity in adolescent teenagers, so these risks are high. As for the epidemiology, we find this retrospective study with this cohort where we assessed over 3,800,000 nulliparous pregnant women under 25 during 5 years in the US, finding that in the group of teenagers, there is a higher risk of premature pregnancy, delivery, low birth weight, and neonatal mortality. Babies born of teenagers under 17 had a higher risk of having a lower Apgar score at 5 minutes. And during adolescent pregnancy, we have a higher risk of adverse events, and the low social and economic level and inappropriate prenatal care and inappropriate increase of weight are the main risk factors. When we assessed the epidemiology of preeclampsia and eclampsia in the US, we found, of course, that maternal age under 20 years was the strongest risk factor, both for preeclampsia and eclampsia, and they suggested improving prenatal care and follow-up of teenager pregnancies. This other study is a review finding that girls under 17 who were pregnant had a higher risk for low birth weight, prematurity, and small gestational age. In this other review, they assessed the perinatal outcomes in teenager pregnancies. They found that between 13 and 15, preeclampsia and preterm births and small for gestational ages were more frequent, and that it was important that this be in girls perimenarchic with a gynecological age under 3. What happens is that we have these major obstetric syndromes. They describe the clinical heterogeneity related with an alteration of vascular adaptation of the spiral maternal arteries during the process of invasion of the trophoblast. This produces a possibility that preeclampsia occur, small for gestational age, restriction of intrauterine growth, preterm pregnancy, and so on. These great obstetric syndromes are associated particularly with disorders of deep placentation, characterized by remodeling of the vessels that is restricted and the presence of obstructive lesions in the myometral segment of the uteroplacental arteries. The main factors are the maturity of the uterus. It's not great. Ontogenic resistance to progesterone, transition to the progesterone response. Another factor is a placenta with a deficit in placentation, disidealization, and immaturity of immunity. Other extrinsic factors attributed are obesity and polycystic syndromes. What happens with uterine maturation or uterine growth during the teenager years? The uterus isn't developed. The cervix may be larger than the uterine body, and the uterine volume and thickness of endometrium increase with puberty. And this uterine growth and the maturation through the hypophysis and axis is inter-individual. We must bear in mind that for this maturation, this has effects in resistance to progesterone, particularly through an action of estrogen and progesterone in the fetus, particularly on the mother's side, that will act at the perinatal area with a small uterus along cervix. It persists during infancy, and during puberty, there's an onset of uterine growth through the impact of estrogen and still rather irregular progesterone. In this study, we could show that the volume of the uterus and endometrium are closely related to characteristic, and they assessed these measurements with a sensitive ultrasound and MRI that both the volume of the uterus and the thickness of the endometrium are enough or good enough through the stage 3 of Tanner, and is completed between 4 and 5 as shown.
Un volumen uterino, entonces. El grosor
Volume of the uterus and the endometrial thickness increase, and the main action is of the estrogen contributing to the growth of uterus and endometrium. And the assessments were done through ultrasound and magnetic resonance of the uterus and the endometrium, and they were directly related with turn 3. And there is ontogenic resistance to progesterone. Here we're speaking of that reduced response to progesterone in target organs, especially the endometrial stroma, where it is intrinsically not sensitive to progesterone at birth. So this prevents birth, prevents the menses and the phases after birth. The phases of estrogens and the fetal luteal phase are completed, especially the estrogenic phase at 7 and a half months, and the luteal phase is completed in the 9th month of pregnancy. The response to fetal endometrium to estrogen and partial response to progesterone at the end of pregnancy, and it is completed with birth and responses to the hormones of the placenta. Now, what happens in the with the placenta in the teen adult pregnancy? It is altered because the accelerated growth of the mother and the not good feeding reduces the proliferation of the trophoblast, and it causes hypoxia, and with a restricted fetal growth with a small placenta. We also see a reverse correlation between the villus surface and the placentary capillaries and the gynecological age, which is one of the key drivers of placental dysfunction during adolescence. And pregnancy interventions in this group may not mitigate the harmful effects of uterine immaturity. So we find a potential perinatal disorder in the presentation in these young girls that are having their first pregnancy. The capacity of hormone response of the endometrium is reduced in the fetus, the newborn, and the girl who's with a cervix that is larger than the corpse, than the body of the uterus. And the plasmatic estrogens and progesterone in circulation in the mother is greater than in the fetus. And the perimenarchic uterine maturation is inertial, with little maturation of the uterine end case. We could then say that partial resistance to progesterone persists in adolescents and may compromise the physiological transformation of those spiral arteries and predispose defects in the placenta in case of pregnancy. Now, what happens in the premature delivery? It is believed that this immaturity of the uterus causes over-distension of the uterus during pregnancy, and it's associated with the response of stress, both to the myometrium and the amnios, releasing more interleukins and tumor growth factors. So the factors that predispose women to premature birth is the inability of the uterus to adapt to a continuous increase in the volume. So this study was conducted especially in women with polyhydramnios and twin pregnancies, and this was then referred to the perimenarchic pregnancies. Another situation is that the sustained estriol and the signaling of progesterone that will cause some factors as MMP2 and MMP9 in the placenta may cause vasodilation and expansion of the uterus. In the perimenarchic stage, this is very poor because of the role of the resistance of endothelial cells in the poorly developed arteries, and that may cause preeclampsia. This study, this is a multicentric study led by Dr. Paulino Vigil in Latin America, and it showed how eclampsia is much more frequent among girls under the age of 20. They also found more ventilatory failure in these women, and these results may even appear with a systolic blood pressure ranging from 135 and a diastolic blood pressure of 80 with a mean blood pressure of 100. And this very often shows that we may have a girl with 130/80 that will develop preeclampsia, and we can't minimize these findings. Another evidence of this study in adolescents with postpartum bleeding in Ecuador, they found that very frequently there are causes such as anemia during labor and eclampsia, preeclampsia that can lead to postpartum bleeding. And Coelho published the cases of severe preeclampsia and eclampsia in South America, and the finding that they that girls under 15 had were at a higher risk of dying and premature births. So as a summary, we see that teenage pregnancy may worsen the risk of adverse results and be the key pathologic driver. Apparently, this is due to uterine immaturity. The gynecological age is much more important than the chronologic age. If we have a patient with a gynecological age that is low, she's at a higher risk of uterine immaturity, and the growth previous to menarche and the loss of ontogenetic resistance to progesterone are essential for vascular adaptations during pregnancy. The process of immaturity in this population will cause risk of large obstetric syndromes, regardless of the social condition, and makes them a population of risk for obstetric emergencies. So with this, I invite you to participate at the Latin American Congress of Child and Adolescent Congress in Lima, Peru, from the 26th through the 28th of September. Thank you. Thank you, Fanny. Thank you for sharing your video. Let me now invite Dr. Rodolfo Gomez Ponce de Leon, Advisor of Sexual and Reproductive Health in CLAP. He will share the Immediate Contraception Post-Obstetrical Event Initiative, Preventing a Second Pregnancy. Thank you, Gabby. Thank you. I want to thank the co-organizers of this event. Let me talk precisely about an element that will enable us to do a secondary prevention, the pregnancy of second pregnancy, that is the reversible, longer-acting contraception, postpartum and post-abortum, and that is what we call IPO, or Immediate Contraception Post-Obstetrical Event. We know that in the region, the repetition of maternity during adolescence for all of the causes that we heard this morning, we know that during adolescence up to the age of 20 years, 60 or 65% of adolescents repeat a new pregnancy before adulthood in countries like Guatemala, Mexico, and Haiti. And the country in this series with fewer repetitions has 36%. There's Costa Rica. So, and considering that our region coverage of delivery and abortion, either spontaneous or legal induced abortions, usually takes place in healthcare centers. So the teenager that went through childbirth and did not receive contraception, this is considered a great failure of the healthcare system, considering the high odds of receiving institutional care, and that there is a high odds for repeating adolescent pregnancy. And if we focus on those under 15, because of the many reasons that were very well described by our colleagues, going from violence, psychological and physical, eclampsia, etc. This is the time when we should prevent a new pregnancy. That is how UNICEF and PAHO got together with other local and regional players to see how we can accelerate the reduction of adolescent childbirth in Latin America and the Caribbean. So interpreting that there are things that have to do with law with gender norms and with inequity, gender inequity, and especially the quality of services, focusing on the adolescents. We understand that access to contraception is but one of the elements, but we understand that in this network of causes and effects that will enable us to reduce adolescent pregnancy. I want to state this very clearly because now I will focus on one of the elements of the healthcare system, that is contraception. It's not a silver bullet, it is a very important element that must be considered with some specificities. So we published 7 actions that experts agreed upon. There was a consensus of experts that showed to be very strong in reducing unintentional pregnancy. First of all, to increase the visibility of the problem. Second, clearly defining the messages and the interventions to the most vulnerable populations. Involve and empower the adolescents, girls and boys, no longer use interventions that are not effective, including sexual education of abstinence. We understand that clearly it doesn't work and should be abandoned only as an example. Strengthen the intersectoral collaboration. As was very well pointed out initially, this is not just up to the health sector, but also health and development sectors. We should not work at small scales, in small studies or small models, and do it at a national, to large scale. And finally, we must create an enabling environment for gender equality and access to sexual and reproductive rights. This has proven to be the strongest reason. I wanted to stop a minute to speak of the effectiveness of contraception and why we focus on the long-acting reversible contraceptions. Here in blue bars, we use the typical or the perfect use of the contraception. When we look at the tube ligation, 0.5% of the women in the first year of use may become pregnant even with tube ligation. So this could be considered the error, 0.5% error. So there are methods like intrauterine devices that are more effective, 0.2, 0.3%, depending on whether they receive progesterone or only copper. And look at the subdermal implant that has an error rate of 0.05. That is, it's much more effective than ligation, tube ligation, and it is reversible. And in 15 days, the person can recover their natural fertility.
So it isn't the same as using this method as the natural methods as compared to one that has 0.05% error. And thus, for example, the male condom that has a 15% rate of failure for contraception in a typical use and is an excellent method for prevention of STDs. So this combination in teenagers is always recommended. That is a highly effective method, such as a contraceptive, together with a condom. This is a study published in Lancet, where we analyzed with the demand of family planning that was solved with modern methods. And this is a 14-country analysis where the mean for the region was 75%, but there are countries that are quite below: Honduras, Haiti, Guyana, and Suriname, and others above, such as Colombia and Cuba. But observe here at right, where we consider the specific age, we observe that adolescents are the ones that have less satisfied need with modern methods, 55% of teenagers and 73% of adults. So being a teenager is in and of itself a higher risk for not having solved family planning with modern methods. Furthermore, We have great inequalities in our region, as shown in the upper graph. We see how much of the demand is satisfied with modern methods according to the quintiles of poverty or wealth: green, the poorest, and red, the richest. In one same country, the younger teenagers that are poor have much less access as compared to the rich ones. And below, in the rural or urban areas, we see that teenagers in the rural area have much less access to modern contraceptive methods. And if we consider income, we observe that in this document published by PAHO in 2020, we have this analysis of the wealth quintiles. The richest ones have a specific fertility rate of 53%, 53 points. But if we look at the poorer teenagers and lower percentile for wealth, they have nearly 2-3 times more possibility or risk of becoming pregnant during the teenage years. If we analyze public health interventions and see the expenditure and protection at 5 years, we observe that the intrauterine device implants, vasectomy, are the most cost-effective methods. So countries intervening using these measures save money and prevent the largest amount of unintentional pregnancies. Why is postpartum important? Why is the inter-pregnancy interval so important, particularly for teenagers? Why guarantee the teenager doesn't become pregnant again fast or in a short period, or what we call the intergenetic interval? A new pregnancy after a live fetus has a higher risk if they become pregnant in 6 months. The risk for abortion is 600 times greater, for miscarriage 230 times more, and similarly for maternal death, newborn death, a low birth weight, the risk increases where this interval is shorter. And following 6 months following an abortion, we also have a higher risk of low birth weight, anemia, preterm in the following one, and particularly this increases when the interval is much shorter, between 1 and 2 months. Therefore, it is crucial to protect the health of teenagers and that they do not become pregnant again fast. What did PAHO do in this regard? We launched an initiative to strengthen immediate post-obstetric event contraception with long-term methods. It may hurt, and if I forget the injection, well, copper, it's all sorts of voices repeating things of different sorts that are hard to hear. I'm not afraid. I feel safe. I'm happy. I have no problems. Myths that have been refuted of women who received care, accompaniment, and counseling, real testimonies that have a common point: contraception. Contraceptive methods not only enable prevention of risk or undesired situations following pregnancy, but also allow women to decide what they want in their sexual and reproductive and social lives. As a health professional, you may guarantee this right. It is your role, and it is key. Via this initiative, we will teach you the appropriate tools to respond to the multiple questions that arise regarding immediate post-obstetric event contraception, with this program including different audiovisual parts that make it a training unique experience and include interactive modules, videos, interactive screens, activities, and many more resources. Are you ready to discover everything about immediate post-obstetric event contraception? What are you waiting for? Enter the PAHO platform, take the course, make the most of it, and become an expert in immediate post-obstetric event contraception. So we pass from words to action. Using this module for family planning from PAHO and transforming it into an interactive course in 4 languages, Spanish, English, Portuguese, and French, that is currently being used by nearly 62,000 individuals, of whom most are in the Americas. But if you look, we also have people in Africa and Asia where they're following these courses. The country that has the highest number, that's a top 10, 22 individuals registered and nearly 10,000 people that have adopted the course is Mexico. Next is shorter, it has 6 modules and is in the 4 same languages, but rather focused on the health staff that cares for deliveries and abortions, even in adolescents. And the content of these courses for immediate post-obstetric event contraception have an introduction, a checklist to identify the important clinical items, and at the end, we also have nearly 40,000 people registered. Many of you are surely included or finished it, and after the completion, we have this certificate for the family planning for the first level of care course and the one for immediate post-obstetric event contraception. Some countries have also taken the simulation phase with health professionals participating, gynecologists, GPs, midwives, and obstetric nurses. This is a manner of accessing the interactive course with your mobile. You use a QR code and enter free of charge to any of our courses that are available and are free of charge, I repeat, in 4 languages. This is a health action that we understand will clearly protect the health of teenagers and enable their full development. Thank you so much.
Muchísimas gracias,
Thank
Rodolfo.
you, Rodolfo.
Bueno, ahora le voy a pedir
Well,
al
now
doctor Millán
I will
Salvo que
ask
nos haga
Dr.
un breve
Salvo
resumen de la
to
exposición
briefly summarize these presentations so we can later have questions. Of course, many have already been answered in writing in the chat box. Miriam, the floor is yours. Good morning, everybody. It's hard to do this in a short time. I compliment the speakers. Can you hear me well?
Se escucha perfecto.
Yes. Good. As for the presentation by Maria Eugenia Otero, who referred the implementation of comprehensive sexual education and its significant role regarding prevention of abuse situations, it was very interesting to hear that if we had to wonder about our sexual education, many of us were indoctrinated during childhood regarding gender matters. Oftentimes, the approach is biomedical in this education. Indeed, for those who have gone to the schools, we've observed that the approach focuses on pregnancy risks, STIs, when ultimately education in this field has other branches that ought to be made manifest. This sexual education law 2650 is a right and has contributed with a lot of knowledge, guaranteeing rights for teenagers, and they must include this knowledge, of course. And teachers should also be trained in comprehensive sexual education in order to provide tools for prevention. This comprehensive sexual education is for all educational levels, and according to the level, will have different specifications or intensities in some of the items. We must bear in mind that as we progress in the school ages, we must stress, of course, situations of violence as we see in the social media and the relationship with sexuality, where we observe But these power abuse situations occur, and we must recognize them and know how to manage them so they don't become victims. In summary, the comprehensive sexual education is invaluable for young people and teenagers, including all of those who didn't have the chance of having it in our education. Co-responsibility is important, and she also mentioned the ENIA plan, that is unintentional pregnancy during adolescence. This is a program, a regional program that includes the ministries of health, social security, and education. Thanks to it, we are more familiar with more cases of children and teenagers that state they were victims of sexual abuse. Excuse me, Miriam, but please, a more general comment, because we will have to close soon. Sorry. And another thing she mentioned was the campaigns that are beginning to appear against comprehensive sexual education. Regarding Dr. Sim's presentation, I will summarize it saying the following. Team that must be trained in caring for teenagers, and if possible, we want an interdisciplinary team. We must consider trauma, but not investigate it in the first interviews, recognizing that trauma during childhood and adolescence oftentimes is re-experienced during pregnancy and delivery and has many, many complications for the future life of the person who suffered it. We must know how to ask, how to wait, and manage a good transference with patients to help to manage all these manifestations that re-experiencing the trauma could cause. Of course, physicians and patients have their barriers. Physicians must be trained. Oftentimes, they struggle against the lack of time, a large number of patients they must see, and we must bear in mind that trauma in the early stages can be manifest later in life, and this will help us to understand how to help to reduce it. We must consider the past trauma indicators and, of course, as we always say, have a good team with people trained, teaching students how to not repeat questions that have already been made and guide them in every monitor, creating a safe and warm environment and indeed validating the patient's anxiety.
As to Fanny's presentation, she gave us a very good description of the pathophysiology of the large obstetric syndromes can cause, not just from an organic point of view. We have to acknowledge that the pregnant adolescent is not only has an impairment of her body, but her mental health. She gave a detailed explanation of the spiral arteries and why pregnancy in adolescents is always associated with a higher mortality risk. Yes, let me finish with the last presentation on the importance of the immediate contraception post-obstetrical event, and I want to highlight this, not to miss opportunities, childbirth, abortion, whatever event we can, we have to make the most of it to ensure long-acting contraception, reversible contraception in adolescents. Thank you, Miriam. Now let me give the floor to Dr. Silvia Zdrovic, who was actively involved in the organization of this event. She will receive some questions by the audience, and those that we don't have the time to answer, we'll try to answer them via email. So thank you, all of you. It's a pleasure to see such an active chat of Q&As by where all the participants and the speakers intervened. Let me start by saying that if we don't have time to answer things in the chat, we will gradually answer them. You can have access to the recordings in your countries, and we are going to ask a question. Judy, there's a question for you. I don't know whether you need a translation, but it would be, what strategies have you been able to work out? You answered that in the chat, but I would take it as part of the summary. What have you done when the girl or the adolescent where the protection system, either the health or the social protection sectors, were unable to protect them? Do you have any further strategies that you can apply later to add to that?
Respond in English, but I understand the question, Sylvia.
Yes,
but
please.
because we have translators, what do we do when it seems like our health system and our social services and our law is not protecting our adolescents who are pregnant? And this is a big frustration. In the United States, less than 1% of children who are victims of sexual abuse actually have the perpetrator incarcerated or even see a trial. So it's so important that we are a safe space and try and care as much as possible for these children. Some things that we do is we look for good psychologists that can provide trauma-informed cognitive behavioral therapy. It has been shown to be the most effective in helping people adjust to trauma. Second is to build capacity to look for strength where we can in a protective family member or a protective teacher, to ask the students, to ask our patients, is there somebody that helps them feel safe so that they can have somebody who is advocating for them? And to build capacity and strength through education. The other thing that I think is so very important, if all we have is the one-on-one time in that personal visit, simply having somebody that says, I believe you, what happened to you is wrong and traumatic, but your body is going to recover. You are strong, you are healthy, you are not damaged, which many of these girls feel, are ways that we can very individually try to help these girls. And of course, we keep fighting. The family may have reported the perpetrator, the child may have, but we need to as well. We as providers are in positions of power. So putting our voice there is important as well.
Muchísimas gracias.
Thanks a lot, Judith, and thank you for being brief and such a compelling answer. Unfortunately, because of time constraints, we're going to have to put an end to this session here. We've answered some questions in the chat, and if we haven't answered, we are going to answer them in the forums. Let me add, because we received a message, and I think it's worth it because it's a very important tool for the countries that are in Latin America and the Caribbean, that from UNFPA, and this is something that Dulce Chahim from the Dominican Republic is telling us, UNFPA gives us, enables us to improve coverage of the long action methods that are so important for this. So thank you. And now give the floor. Thank you, Sylvia. Now Marisa Lavovsky will close, and maybe those of you maybe the speakers could turn on the camera so that we can take a picture. Melina, could you help us while Marisa closes the session? Thank you. Yes, I want to thank Susana, Rodolfo, and Melina for enabling us to do this, because for all the societies, the International Federation, Latin American Federation, Argentina, NASPAC, and the Paraguayan Society of Child and Adolescent Societies, it would be very difficult to get together with simultaneous translation and being able to share it later globally. So I want to thank the three of you, and I want to thank all the speakers, of course. Very, very clear presentations. Organizing things like this is a joint effort. I'm sorry, but the train is about to pass. I can't avoid it. My apologies. But thank you all. I believe that working on sexual and reproductive health is clearly part of human rights. It's essential that under the age of 15, education is of primary importance, because girls under 15 usually suffer abuse, although not all of them, and that education is the basis of prevention. As Rodolfo said, if it already happened, and using the methods and long-acting reversible methods that are more effective even than vasectomy and tube ligation, they don't require anesthesia or admission, and they can change their mind. Somebody mentioned abstinence. Abstinence is not good for contraception. Of course, it is available if you're religious, if you think that it's the way to do it. Of course, all methods may be used, but it is not as effective. Well, it's not effective, and I'm saying it because there were some comments. The lessons will be recorded in English and in Spanish. You have the links both in the website of PAHO and all the societies, and I hope that we can continue to work so that we can reach many more places. This is what the pandemic left us. The good thing about this is that it enabled us to reach all the corners in an easier way. So without further ado, Saturday weekend, get fun, and thank you for participating, and thank you for being here, because we still have 324 people. So thank you all. So thank you. Goodbye. Thank you.
Felicidades, Marisa y Silvia, y a todos. Gabriela, fue fantástico.
Gracias,
Judy.
participación. Muchas gracias.
Thank you, Judith.
Thank you, Rodolfo.
Nice to meet you.
Nice to meet you as well. Ciao.
See you soon. Bye.
Hola a todos, chao a todas, buen fin de.
Dios, que estén muy bien. Gracias.